Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. We'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box that you see at the bottom of your screen. I'm joined by two guests. First, Dr. Brian Garibaldi, who's the director of the Johns Hopkins Biocontainment Unit and an associate professor at the Johns Hopkins School of Medicine. Brian will give us an update about the treatment of COVID patients. Then we'll hear from Dr. Bill Moss, who's executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give us an update about COVID-19 vaccines. I'm now going to turn to each of our speakers for a brief overview. Brian, first to you. We're hearing that some states are near crisis in terms of available beds, especially ICU beds for COVID patients. Can you give us a sense of what you're seeing on the front lines in the hospital?
Sure, Lainie, that's right. Across the country, there are many areas right now that simply don't have either the physical space or the staffing capacity to take care of the thousands of patients who are hospitalized with COVID across the country. We've been a little bit luckier here in Maryland. Hospitalizations are definitely on the rise, but just to give you a sense, at the beginning of the summer, we had less than 100 patients hospitalized in the state of Maryland for COVID. Now we're up over 800. What that's meant is it's meant reopening some of the dedicated COVID units that had been closed for part of the spring and most of the summer, shuffling around ICU bed capacity so that we can continue to take care of the COVID patients who are requiring ICU level care, but also continue taking care of other patients with other diseases who require ICU level care. I would say that this is certainly true in Maryland, but also in other places in the country. I think the stress on staffing levels has been quite significant. There's been so much turnover of frontline healthcare workers, particularly nurses, because of how taxing the last 18 months have been. And that's really been a key resource that every hospital is scrambling to try to make sure they have enough staff to take care of patients, particularly in the intensive care unit. Over the last month, almost every case that I've seen coming to the intensive care unit with COVID has been someone who's unvaccinated. We occasionally do have patients who have immune system problems, who didn't respond to the vaccine, who end up becoming very, very ill. But by and large right now, this is a disease of the unvaccinated. And it's really heartbreaking. There are people who are coming into the hospital who are wishing they had gotten vaccinated, and for a number of different reasons didn't do it before they got sick. And once they're sick, it's too late. And so I would really encourage people out there, if you're thinking about getting vaccinated, the evidence is quite clear that right now the risk of hospitalization is in some cases as high as 50 times higher if you're unvaccinated, and the risk of death is far higher if you're unvaccinated compared to being vaccinated. The other thing that we have not seen, thankfully, in Maryland, or at least in our hospital, we have not seen a rise in the use of unrecommended therapies for COVID like ivermectin. That's received a lot of press in the news lately. Ivermectin's been studied in COVID. It is not an effective treatment against COVID. It doesn't prevent you from getting it in the first place. It doesn't keep from getting hospitalized, and it's not a treatment that we use to try to get people through their acute illness. So I would really encourage people, if you think you have COVID, please go get tested. We do have some outpatient therapies that you may be eligible for, and with monoclonal antibodies. We even have the ability to give those as prophylaxis if you've been exposed and you're in a high-risk group. But I would really urge people not to try taking over-the-counter supplements or trying to get their own stock of medicines like ivermectin, because they're going to do more harm than good. And we actually may have some therapies that can positively impact your risk of coming to the hospital or getting sicker.
Thanks so much, Brian. I'm now going to turn to Bill. Before I do, I want to remind those who are watching, please do continue to submit questions in the box at the bottom of your screen. I see them coming in, and we will move to Q&A shortly. Bill, yesterday, President Biden announced new measures to increase vaccine uptake throughout the United States. Do you anticipate that this is going to be enough to significantly move the needle? so to speak?
Yeah. Thank you, Lainie. I think these measures will help. This has been a very challenging problem, but I thought, Lainie, if you and the viewers will indulge me, I recently came across a letter that was written to the president of the College of Physicians of London and Edinburgh in 1825, so almost 200 years ago. And I'd like to read this letter because it just really resonated with me about the situation we're in right now. So I'm just going to read, a couple sentences from this letter. Again, published in a medical journal in 1825 by a Dr. Ferguson, and he writes. About 20 years ago, when it was proposed to purify the medical profession from quackery and ignorance by legislative enactments, the late Dr. Gregory of Edinburgh published a letter on the subject in which he remarked that, quote, England is a free country, and the freedom which every free-born Englishman chiefly values is the freedom of doing what is foolish and wrong and going to the devil his own way. That's the end of the quote from Dr. Gregory. And the letter continues, this is strikingly exemplified in the present state of vaccination in Great Britain, compared with its state in other countries of Europe. In the latter, general vaccination was ordered by the government. No one who had neither cowpox, which was the vaccine, nor smallpox, the disease, could be confirmed, put to school, apprenticed, or married. By such means, the mortality from this disease in 1818 had been prodigiously lessened. And then he goes on to describe the declines in mortality in a number of cities and countries throughout Europe. And then he continues, in England, on the other hand, in England, the native country of this splendid and invaluable discovery, cowpox vaccination for smallpox was discovered in England and promoted by Edward Jenner, where every man acts on these subjects as he likes. Crowds of the poor go unvaccinated. They are permitted not only to imbibe the smallpox themselves, but to go abroad and scatter the venom on those whom they meet. And there's just so much here that kind of captures our current situation. And I just want to remind our viewers that was written 200 years ago in 1825. So President Biden's message yesterday, I think, was primarily addressed to unvaccinated Americans. And I think he made some very pointed statements about the unvaccinated, highlighting the fact that more than 2 million Americans have gotten at least one shot, that we have an approved vaccine, the Pfizer vaccine, FDA approved, and that unvaccinated people, by filling our hospitals and ICUs and stressing the healthcare system, as Brian just alluded to, is really impacting all of this. And as President Biden said, leaving no room for someone with a heart attack or pancreatitis or cancer. So his plan, he laid out 6 points. I'm just going to highlight on those related to vaccines. And I think for vaccines, he really highlighted 3 groups: how to protect the unvaccinated, how to protect the vaccinated, and what we can do about those who are still ineligible for vaccines, children 11 years and younger. So for those unvaccinated Americans, we have tried both carrots and sticks in this country, and I think he laid it out pretty strongly around vaccine requirements, and with a plan that could affect 100 million Americans, or 2/3 of the workforce. Very briefly, requiring all of those in the executive branch employees and federal contractors to be vaccinated, that all private sector businesses with more than 100 employees require that their workforces be vaccinated or be tested at least once a week, extending vaccine requirements for healthcare workers who treat patients on Medicare and Medicaid. And he really reached out to physicians, primary care physicians in the United States, recognizing that they're a trusted voice to encourage their unvaccinated patients to get vaccinated as soon as possible. Now, the second population, or how do we best protect those who are vaccinated, who received 2 doses of a mRNA vaccine or a single dose of the Johnson & Johnson vaccine? And here I think there is a little more nuance, and President Biden said in his speech. Now, I know there's been some confusion about boosters. There's even much discussion about whether we should be calling them booster doses or whether they're really a 3rd dose in a 3-dose series. I think what he pointed out is that the government is prepared to have Americans receive an additional dose. They purchased the doses; they're ready to go. But there's still more discussion and more data analysis here. We still need to wait for an approval or authorization from the Food and Drug Administration that an additional dose would be safe and effective. And I think even more importantly, we need to wait for recommendations from the Advisory Committee on Immunization Practices and the CDC on booster doses and who should get them and when. I think we are seeing some data and some signals, and they'll be increasingly so, to suggest that in some populations, particularly older adults, I think most strongly in residents of long-term care facilities, that they could benefit from an additional dose. Healthcare workers as well, possibly. There are still issues around global vaccine inequities, and I'll touch on that briefly. The third group are those who are ineligible, and President Biden talked about all the different measures we need to protect our students in school. Obviously, those 12 and older can and should be vaccinated. It's an under-vaccinated group. And obviously, there's a lot of concern and question about when we are going to be able to vaccinate children younger than 12 years of age. As we've talked here before, Pfizer will be the first in line for this. We're expecting their data on the safety and efficacy of these vaccines in children younger than 12 years of age later this month, early October, and then those data will have to be reviewed by the Food and Drug Administration before we see authorization or approval. So we're still a month or two away, I think, for this. I know there's a lot of interest, obviously, with children going back to school. There's I'm just going to touch briefly on some of the other news, I'll say, and areas of interest. We are seeing more differences, I think, between some of the vaccines. Some differences between Pfizer and Moderna, both immunologic data and efficacy data, suggesting that perhaps there's a more durable immune response with the Moderna vaccine. Still more to learn about that. The Moderna vaccine does have a higher dose of mRNA and was given at a longer interval, 4 weeks compared to 3 weeks. That could potentially explain some of that. Also seeing data about the durability of the adenovirus vectored vaccines. And those adenovirus vectored vaccines could have longer durable immunity, but still more to learn. Also new data coming in and more to come on mixing and matching vaccine doses. I think we've talked before about data from the UK on a AstraZeneca adenovirus vectored vaccine, followed by Pfizer, showing very strong immune responses. Lastly, Lainie, we still have issues with global vaccine inequities. COVAX recently kind of scaled back on the number of doses that will be available by the end of this year. Their originally hoping for 1.9 to 2 billion doses, getting out to low and middle income countries, scaling it back to 1.4 billion doses. And I'll just end up, President Biden did address this issue yesterday at the end of his speech, highlighting the fact that the United States has given more vaccine doses than any other country, 140 million, with imminent plans to ship another 500 million doses of the Pfizer vaccine. But we're still way behind what we need to do globally to address some of these equities and really shut down virus transmission so that we prevent the emergence of new variants.
Thanks so much, Bill. I like how you upped our game with the history of public health, and it also makes you wonder, what will historians one day make of this pandemic when they look back on it. I want to remind those who are watching, please submit questions. I am keeping an eye as they come in, and you'll see a banner on your screen to subscribe to our weekly newsletter. It's called The Week in COVID-19. It is a great way to get information in your inbox every Monday about the latest developments with the virus itself, variants, vaccines, and other critical trends. And I'm now going to move to your questions. Brian, I'll start with you. In your opening remarks, you spoke a bit about what you're seeing in the hospital in terms of those who are vaccinated versus those who are not. Could you expand on that a bit? Of course, there's lots of interest and questions that are coming in about what's really going on in the hospital. Are you seeing a lot of hospitalized individuals who were fully vaccinated?
Yeah, so I think it's really important to remember that no vaccine is perfect, right? And so when we have widespread transmission of this virus in the community, there are going to be people who are vaccinated who become symptomatic and become ill. But by and large, the risk of getting hospitalized or dying from COVID is so much higher in people who are unvaccinated than vaccinated. We have seen people who are fully vaccinated or have received both of their shots or a single shot, if it was the Johnson & Johnson vaccine, get sick and come to the hospital. But in almost all of those cases, there's some reason that person's immune system did not respond to the vaccine. Either they're immunosuppressed, they have a chronic condition that requires them to be on medications that can alter the immune system's response. But you can also sometimes see that in older individuals, right? So if you look at the age of hospitalized patients who are vaccinated, on average, they're about 10 to 15 years older than the unvaccinated people who are getting hospitalized. And so, there certainly are people who have been fully vaccinated who can get sick enough to come to the hospital, but the vaccine is tremendously effective at reducing that risk. But when there's widespread transmission and there remain people who are unvaccinated in the community, there is still a risk to vaccinated people of getting sick, but the vaccines really do work. And if you haven't been vaccinated yet, I wish I could come up with a way to convince you that you need to protect yourself and to protect people around you.
Thanks, Brian. Another a clinical question for you. Do you feel like you're seeing more instances of individuals losing sense of taste and smell as we're in this current Delta variant surge?
So that's something that's been kind of popping up here and there, and we don't have enough data yet to really understand what the differences in presentation between Delta and particularly the UK variant or the wild type virus that we saw a year and a half ago. I think there's some concern that maybe the symptoms are changing a little bit, and that in fact maybe fever and loss of taste and smell might be a little bit less common with Delta. And so, I think certainly if you have those symptoms, you should get tested. But I don't think it's a slam dunk. We're seeing lots of people who don't have those symptoms who end up having respiratory issues coming to the hospital with COVID pneumonia. So I don't think you can use that reliably to say, well, I can still smell, I can still taste. Well, this is not COVID. And that's never been true, right? We can never use that to exclude it. But right now, if you do develop those symptoms, I would still be really, really suspicious that you had COVID and that you would need to get tested.
Thanks, Brian. Bill, a question for you about vaccines and variants, and we know that we will keep hearing about additional variants. Delta is the focus of the moment, but there's certainly reason to believe that it will not be the last variant that we're talking about. Do those who develop vaccines have an ongoing ability to match the vaccine to additional variants? How confident can we feel about that process?
Yes, I think this is a really important question, and I think it is one of the I'll say remarkable features of these newer vaccine platforms that are based on the genetic code or genetic recipe for the spike protein. And I'm specifically thinking of obviously the mRNA vaccines, the Pfizer, Moderna, and the adenovirus vectored vaccines, whether it's a J&J or an AstraZeneca vaccine. And so it's relatively straightforward for the vaccine manufacturers to swap out the genetic code from the original strain that was first identified in Wuhan with one for a variant. And I know the CEO of Pfizer has said that probably takes the company a couple months, 2 to 3 months, to be able to do that. So it's not a big technical hurdle to be able to adapt these mRNA or adenovirus vectored vaccines to a new variant. And in fact, the vaccine manufacturers are doing this as we speak with the spike protein code, genetic code from the Delta variant. And I anticipate that we'll see reformulated vaccines probably, maybe in the first quarter of 2022 or so. So this is relatively straightforward from a technological point of view. There are still regulatory issues to be worked out. Many of us think that the FDA will probably handle such a vaccine as they handle the annual influenza vaccine and not require, extensive clinical trial testing data in order to authorize or approve such a vaccine.
Thanks, Bill. Another question for you, something that came up briefly in your opening remarks was the potential for waning immunity over time. So can you elaborate on that in terms of the COVID vaccines, but also give us a little more context? Is that typical for any given vaccine?
Yes, I think this is critical, and I don't think we've done a good job really on the public messaging from this on this point. We can. First of all, we often use, and you often see reported, immunologic data. And immunologic data is very important, but it often doesn't tell kind of the whole story. And I'm thinking particularly of antibody levels. And we know that there's a strong correlation between neutralizing antibody levels and protection, and that's what we would expect. But it's also another thing we expect is that after vaccination or after really natural infection with SARS coronavirus 2 or any pathogen, there will be a big boost in antibody production. Antibody levels will go up, but then they come down over time. And that's just a normal part of our immune response. And I think we've said before, we can't maintain high levels of antibodies against every pathogen that we've seen, or our blood will just become chock full of antibodies and wouldn't be able to flow through our system. So that's normal. And then on re-exposure, though, we have these memory immune responses. And so on re-exposure, our immune system and our antibodies are much more specifically targeted to the pathogen. That immune response rises much more quickly and much more strongly. So we also expect, after additional doses of a vaccine or after re-exposure to a pathogen, that we're going to see a boost. Now, what we are seeing some evidence. So that's the immunologic side. What we're really concerned about is, more on the clinical side, I'll say, whether we're seeing reduced protection over time or in the face of a Delta variant, and those two are hard to separate sometimes, against either infection or mild disease, but more importantly, severe disease, hospitalization, and death. And I think the bottom line is that over time and with increasing dominance of the Delta variant, we have seen decreased vaccine effectiveness against infection and mild disease. But we've also seen sustained high levels of protection against severe disease, hospitalization, and death. Maybe a slight decrease, but still at very high levels. The one group where I think we may be seeing some decreased, perhaps, vaccine effectiveness is in older adults, as Brian was referred to, those who have weaker immune systems, whether it's because of comorbidities or drugs or just the aging phenomenon. There is some evidence of decreased effectiveness against some severe disease, but these vaccines overall still remain very highly protective. We're not seeing waning immunity against severe disease.
Thanks, Bill. And a somewhat related question. For individuals who know that they had COVID, they had a positive test, what is the advice in terms of vaccination? Folks are asking if it's a 2-dose regimen, if it's Pfizer or Moderna, do they really only need to get 1 dose? What is your advice?
Yes, this is an interesting and complex question. I'll tell you, the recommendations right now are from the CDC are that individuals who've had COVID, that they will be better protected and should be vaccinated. And ideally they would wait until basically after their period of isolation or quarantine is resolved. So that's several weeks, and they can and should be vaccinated. And the rationale there is that we don't understand well the magnitude and duration of immunity conferred by natural infection. I will be very honest, though. There are people will be protected after natural infection, probably more so if their disease has been more severe than if they've had just mild or asymptomatic infection. But to be absolutely sure about the magnitude and duration of protection, those individuals should be vaccinated. Now, I think there'll be ongoing work as to whether a single dose, say, certainly a single dose of Johnson & Johnson, but whether a single dose of an mRNA vaccine is sufficient in those individuals. We know that boosts their immune system, but right now the formal recommendations are that those individuals be vaccinated.
Thanks, Bill. Brian, question for you. So we have this very large group, the under 12s, who are not yet eligible for vaccination. What's your advice to parents? What can folks be doing to keep that group as healthy and safe as possible? Oh, I think that Brian may be having a technical difficulty. So Bill, yes. I'm gonna send that to you. Yes. I'm sure I'll be back in a moment.
Yes. So, this is obviously a big concern to many, many people in the United States with our children going back to school. And as I said earlier, I'm hopeful that in a couple of months, we will have an authorized or approved vaccine, initially the Pfizer vaccine for children at least 5 to 11 years of age. But in the absence of that, there are a number of things that can be done. First of all, in school settings, the adults and children who are 12 and over should be vaccinated so that we're surrounding those vulnerable children, those susceptible children with vaccinated people. We know that, kind of creating that protective bubble of vaccinated people around unvaccinated people is very powerful. The other thing are, the basic public health practices, the masking, the social distancing, good ventilation in schools, the testing that can identify infected individuals very briefly. And I'll just say President Biden did address this issue in his plan yesterday. So those are kind of the big things we need to do to protect the susceptible children in our school system.
Thanks, Bill. And we are right at 12:30, so I'm going to wrap. I'd like to thank Brian Garibaldi and Bill Moss for joining me today, and give a big thank you to everyone who joined us in the audience, and especially to those who submitted questions for our experts to answer. This briefing will be archived and available on coronavirus.jhu.edu. As a reminder, we offer these 30-minute briefings regularly on Fridays at 12 p.m. Next Friday, we're going to do something that's a little different. We'll have the second installment of our Pandemic Data Initiative Expert Forum, and that will focus on return to school and the importance of data for leadership and policy in schools during this pandemic. So I will look forward to seeing you next week at our upcoming forum. Until then, thanks and stay safe.